times when you have to use SKS. If you have a crash, like you're doing a left main stenting and a guide catheter engagement, leads to a dissection which is spreading into LAD and circumflex, you of course do a quick SKS, and this is one such situation where this was a seropositive patient, anterior wall infarction, and we do an angiogram, and you can see actually two lumens which are stretching from ostium of the LAD, one going to distal LAD and one going to circumflex. Same is seen here. So the point is you have to preserve flow into both these vessels, and this is why we have actually two wires. I'm sorry, the loops are not proper. Somebody can do to the loops. So as you can see here, two separate wires. You have to make sure that you're in the correct lumen. And this is as if we are pushing the carina back towards the ostium of LAD. And this is the final result on this stent. If we had done any other technique, we would have probably lost the side branch. You would have kept pushing things into sub-intimal space. So this was a very strong reason why we should, it's moving on its own. Can somebody change that? Don't move. So this was a case where we have, can we run that? We have a lesion at the mouth of the ramus, and we did a V-stenting with two stents at the ostium of LAD and the ramus to come out with this kind of result. So both SKS and V-stenting will have its own positives in some given situations. So if you see how things have changed for bifurcation over last some years, this is actually 2012 data, which clearly shows that the problems related to bifurcation have gone down, and there is a clear improvement in the overall angio success when you check these patients on follow-up. The important issues are the part and the final case. So I think in our thinking, we must have these two done on regular basis. In general, we all believe that one stent strategy is preferred to two stents. But my own feeling is as time goes and we get better and better stents performing better in longer term, the two stent strategy would improve its percentage versus one stent. So when you're using one stent strategy, final kissing balloon is to be done only if needed. So you put one stent, if you're planning only one stent, look at the side branch, and only if you're going to address the side branch with balloon, you use kiss, keep a balloon in the stented segment. This is primarily to preserve the polymer on the stent. So when you see two stent techniques, so we have planned to have two stent techniques, and your angle is narrow. Culottes becomes your technique of choice, especially if the two branches are of equal size. If main branch is bigger, you could opt for a mini crush. If you have an angle which is wide, more than 70 degrees, you can probably opt for modified T. But whatever you do, modified T, culottes, or mini crush, a final kissing technique is a must. That's something which is really going to improve your long-term results. So when you're preparing for bifurcation stenting, an upfront preparation of the lesion is extremely important. This is actually going to improve your chances of successful one stent strategy. If you have decided one stent, it will probably help you to come up with one stent, and also would lead to a better stent expansion at the end of the procedure. So preparing very well with whatever technique you want. It could be conventional balloon, non-compliant balloon, cutting balloon, or a rotablator. This is actually going to be very, very important. Also, since you're going to be taking 2 stents, a guide catheter of appropriate size is very important. Many times we change the strategy and then try to go from 6 to 7, which is so many times messy. And also accept less than 70 degrees side branch stenosis. Flow is good, lesion is very mild to moderate. I think better to leave the side branch unaddressed. FFR, of course, would help you decide whether side branch can be left without stenting. Then appropriate therapy in preparation would be rotablator if you have sizable calcium. IOS, of course, will help you to plan your strategy. It would tell you there is a calcification, what is which way, especially the restenosis happens at the mouth of the side branch. So we have to prepare that area very aggressively. And if PTCA to the side branch is needed after main branch stenting, we should be doing a kissing balloon. The way to do it, you could do a double crush or conventionally a single crush. We may talk about it later. But if 2 stents are needed, it is mandatory that rewiring of the side branch and performing final kiss is done adequately. So always plan it this way. When do we use 2 stents? When you have a major dissection in the side branch, you have a severe stenosis in the side branch, especially in a side branch which is large and long. So a sizable myocardium is dependent on the side branch. I think you would definitely like to take 2 stent strategy by choice. POT, of course, a strong necessity, because once you do POT, you're actually pushing this portion of the stent against the wall, as you can see here. So when you're doing POT, your balloon, non-compliant balloon, should limit itself proximal to the origin of the side branch. We should be doing only POT in this area. Many times, same balloon is brought forward and you start dilating from here backwards, and that's not going to be what POT intends. POT actually allows you to remain in the lumen of the stent and then get an access which may be very distal, and that's what you want when you want to rewire the side branch. So these are big advantages which POT offers. More importantly, these are all techniques, but even the stent choice is extremely important. So access to the side branch, if you have a bigger sort of opening to take anything into the side branch, it may be balloon, it may be stent, it's going to be important. Opposition to the wall of the vessel, again, very important. So typically you have one stent going like this from LAD to say left main. So you have to flare the left main and LAD diameter remains same. So the stent should have a capability which would allow you to stretch. Also, these days you do so many imaging where you put IOS, etc. through the stent. So this longitudinal compression should be avoided. We all know that the longitudinal malformation is a worry when you're taking things inside. This may also include if you're putting one more stent from behind. Sometimes the stent doesn't go, and you may have to sort of struggle as you get the stent in. And of course, the proof of the pudding, stent must have a good long-term result, which would tell us that, yes, the stent is going to be effective. So important aspects when you choose a stent is going to be optimal apposition, overexpansion capacity, a large side branch access, and to provide good scaffolding. So these are the parameters on which you make your decision. So the stent struts, which are actually square, having square in nature, and rounded struts, this also makes a difference. And in this particular case, if you have a deployed stent, you're trying to go to the side branch, and the square struts will be obstructive. In contrast, rounded struts will allow the wire to slip over the rounded edges. And this is how the access to the side branch is clearly improved. This is a squared struts where side branch may find it difficult once it hits. while rounded struts will allow. So this is actually a peculiarity of resolute integrity, which is going to be very effective in getting to the side branches. Then the access to the side branch, the kind of gap you can get without disturbing anything on either side becomes very important. So we have resolute integrity probably giving you the maximum opening to the site compared to Promus element. So this is actually a help when you're trying to take a bigger diameter stent to the side branch and ending up with T or mini crush kind of stenting. So of course, the choice of the hardware influences the procedural outcome. And you all must think, all stents are not the same, and depending on what you're dealing with, you should be using your stent options. Then the stent design, you would probably have many stents which are actually slotted tubes. So they would have connectors which are actually joining these loops, while the resolute design has this sinusoidal designs, helical wrap on this, and just a laser fusion at these spots. So these are all again going to be very helpful when you go to the side branch and you're trying to access the side branch. So the malapposition, again, especially in the main branch, remains an issue. And there is data which says that almost 11% stents are malapposed. So you have to be very aggressive in dilating. So bring both the kissing balloons back so that you get an adequate dilatation in the proximal portion. But even here, the stent design influences the position in the bifurcation lesions. This is one study where the 3 stents, Integrity, Multilink, and the Omega from Boston are actually compared. And you see the apposition is indicated in red. If reds are minimal, that means the stent is well opposed. So you can see with resolute integrity, the stents are very well opposed. So now this is going to be important when your distal branch is small and the main branch is going to be big. So if you have a stent which is going to give you a good opposition, you would end up with a good expansion to the wall. Then we all know about the longitudinal shortening, something coming from behind actually hurting the stent. And from this angle, this design of resolute integrity, where you have a compression resistance coming from peak to peak kind of design is very important. So the peaks may just gather together, they won't run into each other, while the offset peak-to-peak design actually will allow the stent to get compressed. So sometimes you deploy a stent, you're taking another balloon from behind, and this balloon can really compress the stent, and you may end up with the longitudinal shortening of this nature. So all these factors are very important and brings us to a latest study, 2016 ACS last month. So we have this PROPEL study where resolute integrity and comparison with Science V, and you can see the integrity has excellent results, almost half of what Science had at the end of 1 year, 8.5 with Science and 4.3 with resolute integrity. And all these had complex, like diabetics were over 40%, bifurcations were over 25%, and small vessels were again over 40%. So on a whole, these are going to be very important factors for resolute integrity. This is actually a resolute pool bifurcation analysis, which clearly shows that resolute in bifurcation has no difference compared to resolute used in non-bifurcation settings. And also, when you compare any technique used, resolute has no difference. So you choose any technique for bifurcation, resolute has a standard result. So the good technique, which I generally follow, can you have the movies running? I generally follow is have a stent in the side branch, keep your another stent in the main branch, deploy this, pull out the balloon and the wire, deploy this, recross, and you can end up with a result of this nature. You can see stent booths showing a very good design. There are also some cases like here, we have a critical lesion in the LAD, which was very calcified, attempted in some other center. And we have a diagonal which is very good size. If you can see, the diagonal is going all the way down to the apex. So balloon inflation was very difficult. These are some of the pictures from the earlier procedure outside. And then we decide to do a rota on the LAD. Note that there is no wire in the side branch when you are doing a rota to the main branch. So once we did rota, you can see the balloon expands very easily. So obviously the resistance that the calcified, not calcified, but heavily fibrotic lesion was offering was not there. So in this case, we have done culottes with, see it's a narrow angle, equal size vessel. So in this case, culottes is a very important help. Actually, the percentage of culottes in our lab has clearly gone down, but in some of these cases, we continue to use these kind of techniques. To sum up, maximizing lesion preparation before stent implantation should improve stent delivery and expansion, allows for easier and more precise stenting, and increases the chances of successful one-stent strategy, and thus potentially improving the outcomes. Bifurcation PCI are complex and warrant modified techniques to improve the outcomes. You may have to change, even if you're started with some kind of technique in your mind. Choice of hardware does matter in bifurcation lesion. Pot is an absolute must. And in bifurcation lesions, following stent characteristics should be extremely important in getting you to a good immediate as well as long-term results. And some of these are overexpansion capacity, side branch access, radiopacity, because you want to touch the two stent to each other, and apposition of the stent, and longitudinal strength. Thank you for your attention.